Good afternoon. I'm Paige Winfield Cunningham, an author of the Health 202 newsletter at the Washington Post, and I'm pleased to be here with three folks who I'm sure will have fascinating insights about a topic that involves all of us, which is the use of better technology in healthcare. Closest to me is Arne Sorensen, CEO of Marriott International. Next to him, Seema Verma, Administrator of the Centers for Medicare and Medicaid Services. And at the end, Larry Merlo, President and CEO of CVS Health. Now, I'm sure I'm not the only person in the room who's gotten frustrated before at the inordinate amount of effort the healthcare system can demand of patients, from facing long waiting times to having to get records transferred from one office to another. But a few weeks ago, I received in the mail a little flyer for my new Aetna plan, which invited me to sign up for Teladoc, which gives me phone or video chat access to a doctor 24/7. And I just mention that because I think this is one of those signs that the healthcare industry is moving step by step towards a more efficient, less costly system where patients can get their needs met without jumping through hoops. So in our time today, I'd like to hear from our panel about how they're working in their own spaces towards this goal of a modernized, technology-savvy delivery system. Let's start broad. What are the biggest challenges to innovation in healthcare today? Larry, let's start with you. What do you see as the most pressing problems that your company is trying to confront, especially in terms of helping consumers make better healthcare choices?
Yeah, Paige, it's a great question. And I think historically, as people have thought about innovation in healthcare, they think about a new drug therapy, a new treatment, new technology with a surgical procedure. But more and more, we see the needs that technology needs to have in terms of creating consumer engagement, whether it's transparency, whether it's pricing of whatever one is attempting to access the healthcare system for. And as you mentioned, today we have a system that has become increasingly complex and not easy to use and navigate. So we're thinking about how can we make transparency actionable. We have a great example where we've had so much focus on drug pricing over the last 12, 18 months. And as we've worked to define that, we've said, well, that moment of truth really starts at the point the prescription is being written by the prescriber. And all of us here in this room, we each have a benefit design, and you can't expect the physician or as individuals for us to know all the nuances. So what we were able to do is take an individual's benefit design and embed it into the electronic health record in the physician's office. So when he or she goes to write that prescription, they can see the patient's out-of-pocket cost, and they can see up to 5 therapeutic alternatives. And what we're seeing is about 40% of the time, the physician is switching to a lower cost alternative, and the average savings is around $125. So it's really an important proof point for us that understanding that root cause and what we describe as that moment of truth, and then bringing a solution to that is what we really need to be working harder and doing more of.
When you're describing one of the biggest problems, which is this lack of communication between the provider and the insurance plan in terms of the medications that are prescribed. Arne, can you weigh in? Can you talk a little bit about the problems you see with employer-sponsored coverage and kind of the innovations that you're trying there?
Yeah, so maybe this is picking up on Larry's comment a little bit. Innovation is obviously a big word. It's an important word. It's what we're talking about this afternoon. And parts of it sound totally innovative, right? About new drugs, about new crunching of data, about looking at populations and coming up with cures and that sort of thing. And we can talk about that because that is relevant to us too as an employer. But in some respects, the most powerful innovations that we have done recently don't feel like innovation at all because they're very basic. So Marriott's 90-year-old company, 91 years old, has been providing healthcare in a way for probably since the Great Depression in the 30s, where a doctor was brought on staff to serve the associates that were there. Before we talked about healthcare as healthcare, but it is part of our legacy. And for all that period of time, we have said, take care of the associate will take care of the customer will come back again and again. And we've taken those two words, take care, and converted them into a very basic but really essential training that includes healthcare connectivity. So that we say to our associates, learn to control your life. Financial planning, healthy living, diet, exercise, but also here is the way for you to navigate the healthcare system. And again, this is a really basic idea, but the healthcare system for so many of us is so complicated that we might learn to navigate it for our kids if we have kids. But if we don't have kids and we don't have an acute health issue, we may not navigate it at all. So maybe we don't sign up for insurance, or if we do, we don't use it. If we've got early indications of diabetes or heart conditions or other things, we may not navigate it until it's gotten so late in the process that it is more threatening from a health perspective, more expensive from a health system perspective. So this take care idea is really about training, helping hotel level associates say, here are your healthcare options, here are the other things you should think of as being part of your healthcare healthy living menu, if you will, and let's make sure we're helping you navigate the system in a way that then allows you to tap into things which seem more like innovation with a capital I.
Well, and both of you have mentioned consumer engagement. Administrator Verma, when you're thinking about this issue of helping consumers take control of their health, what do you see as the biggest challenges?
So from a government perspective, I mean, we're providing health care to over 130 million Americans between Medicare and Medicaid and the health insurance exchanges. And one of the challenges that we're facing, which I think everyone's facing, whether it's somebody going in to pick up prescription drugs or businesses, is the high cost of health care. And we're looking at by 2026, 1 in every $5 are going to be spent on health care. And so from our perspective, as we're looking at big issue problems and how we're going to pay for health care, we really feel like leaning into technology is a way to provide more efficient care, better coordinated care. So as we're trying to solve what I'd say big system issues, one of the things that I think has always been missing in that conversation is unleashing the patient and making that patient, empowering that patient to be a consumer, which we just haven't done before. So while we're trying to solve issues on a big healthcare system level, I'm also trying to think about it from the patient perspective. And we're all concerned about high costs, but when we go into the healthcare system, it's difficult to navigate. We don't know how much things are going to cost, as you mentioned, with transparency. We don't have access to our healthcare record, and we also don't know about the quality. From the CMS perspective, what we're trying to do is empower patients. I'd like it to get to a point where you can take your phone and say, I need X service. And this isn't going to obviously happen for emergency services or acute services, but there's a lot of our healthcare that we know that can be planned, and say, I need X service, and to be able to identify those high value providers that are providing good quality care at the lowest cost, and for you to be able to understand what your costs are going to be and what setting and what place you can go to get the best deal. So one of the things that we've done is we are putting out claims data. So in our Medicare beneficiaries, some 58 million beneficiaries, the ones that are in our fee-for-service program, we're saying we're going to give you access to the claims data. And it's been out there for a while, but they were giving them a clunky list of all your claims and PDFs, and it didn't mean anything. So that's one of the things that we also have to recognize. Just giving patients data doesn't mean anything. It has to be in an understandable format. And so we put this out, what we call API format, so the data can actually be used by app developers. And since we've done this, we've had over 1,300 app developers that are taking claims information, and they're allowing patients to now translate that information into something that's usable. So it's things like organizing their drug lists, or when they go into the doctor's office, they can bring in all of their health history from the claims data, and it can go directly into the doctor's medical record. So what we're really trying to focus on is unleashing data and making it available so that innovators out there can find ways to improve patient care on the individual patient level, as well as making it easier for providers to do their work.
Well, and I want to talk about electronic health records in a minute, but first, so Administrator Verma is talking about cost, of course, but I'd like to hear from both of you. What do you see as the broad goal here? I mean, we're talking about getting people more involved through technology in their healthcare decisions, but what you're trying to move them from point A to B for what's the overall purpose here? What are you trying to change?
Well, trying to make people more healthy. Really, I mean, fundamentally, from an employer perspective, think about it. If I can be selfish that way, a healthy associate's going to be a better performing associate, going to work longer and deliver tremendous value, and they're going to be happier. So you end up with a a really virtuous circle here, which is reinforcing. And, you know, of course, healthy conditions are also less expensive for us. But really it is, of course, you want to manage the costs of this, but you want to really help deliver tools that are usable for folks. So I'll use one. Larry's a great example for this. We reduced the cost of a visit for our associates to the CVS Minute Clinics to $5. Super accessible. I don't know how many locations you've got, but you're everywhere. You're on every corner, and somebody doesn't have to decide, who's my primary care physician, or do I need to go to the emergency room? They can go see somebody who can say, you know what, this is a big deal. You ought to do something about it. Or, I know what you got, and here's a simple solution to it. Costs nothing, very convenient. And that delivers a familiarity with the system in a way that itself builds confidence for the consumer of healthcare, and it helps quickly identify where you've got a big issue and where you don't.
Paige, I think there's a common theme to what I think the three of us are talking about, that we're talking about consumerism in healthcare, but maybe I'd describe it as the retailization of healthcare, where benefit designs are pushing accountability and decision making to the consumer of healthcare. And what we're trying to do is bring more tools, more education, so that they're making that informed decision. And I see the need where we've got to make healthcare more local, because we're seeing consumers want to access care where, when, and how it's convenient for them. As we've been talking, we've got to make it simpler. And when you look at, I think where Arnie was going around, if you just look at the incidence of chronic disease now in our country, about 60% of Americans have one or more chronic diseases. It's about 80% of all healthcare costs. And yet there are countless studies out there that say we can and have to do better. We're not helping individuals achieve their best health, and as a result, it's costing us more. And I think we all see a sizable opportunity there that can improve the quality of life, improve the quality of our workforce, the productivity of our workforce, and begin to take meaningful costs out of the system.
One of the key things in this discussion, of course, is electronic health records, and I know that there's been a lot of discussion on Capitol Hill about this and increasingly in the commercial space. But Administrator Verma, I'd like you to address this because, as you know, physicians' offices have been slow to adopt these records. There have been countless problems with this. I think every time I go see my doctor, they complain to me about how clunky their system is. What are the problems you're seeking to address right now?
So I think there's two issues when it comes to electronic health records. I think there's a lot of frustration from providers around how it works. We're trying to make some changes to the coding system that will make it easier for the electronic health records to be used by providers. So that's one piece of it. I think the second thing, which is a very important concern for me, I'd say out of all the things that we're working on at CMS, our work on interoperability is probably the most significant to really drive the healthcare system in a different direction. After spending $36 billion on electronic healthcare records, what worked was that we have widespread adoption. Almost all hospitals and 80% of physicians are using electronic records. So that's great. The problem is they're not interoperable, which means whatever is, we used to have a file cabinet and all your information, and now we have basically electronic file cabinets, so siloed information. And for a patient, that's frustrating because you're going from provider to provider, you're filling out paperwork all over again, and it's not coordinated and it's not all together. I always tell the story. I had a situation with my husband where he got sick. He essentially had a cardiac event in an airport, and I'm not with him, and I'm trying to communicate with the first responders about his healthcare history, and I don't know, I don't have the information. And it took us a week to figure out what was going on with him. We had all these tests done, and when I left, I said, all right, well, I'm going back to Indiana, so give me the information, and I want the results of the test so we can bring that to his new provider. And they looked at me like I was nuts, and then they gave me a CD-ROM. And so here we are, 21st century, most computers don't even take CD-ROMs anymore. And it really spoke to me about the problems that we're having in the healthcare system. Because there's not a complete medical record, you're duplicating tests, there's patient safety issues, providers are having to make decisions about healthcare not having your complete record. So we've been driving really hard on interoperability. We've changed our programs to not just get providers to use electronic medical records, but to make it very clear to them that that information belongs to the patient. It is their information. So hospitals are going to be penalized a couple of years if they're not giving that information to patients. Incentive programs for physicians. And I think you're going to see us do even more. We think that every part of the healthcare system, if they have your data, they should make that available. I like to think of a new world. I mean, if you can imagine what this looks like, if everybody has access to their complete healthcare record. So from the time a baby is born to be able to collect every healthcare visit that they've had. Imagine also combining that with remote technology. We're all using, or even wearable devices, and all of that information being aggregated in your healthcare record. That's going to build, and in the advent of artificial intelligence, you can take that data and understand your health in a way that we've never been able to do before. If you take all of that information and give it to researchers, imagine what they can do with that. It also allows us to create more personalized healthcare treatments, and it also develops what I'd say evidence-based treatment guidelines so that providers have a better understanding of what works and what works for different people, so we're not wasting time on duplicate tests and treatments. I was thinking about the polio vaccine, and when they developed that, they were taking paper records, right? They were writing down what the results were and aggregating that data. Imagine where we're going to be when we have these complete medical records and what that will bring to innovation and to science. So we are investing a lot of time in interoperability and making it very clear to providers that patient owns the data. And with some of the work that we're doing on APIs, what we're saying, the patient can take that data, put it into an app, and those apps can do a lot of exciting things with the information.
Well, this picture you're painting sounds very promising, but of course, as you know, that also raises concerns around privacy.
Yes.
And all of this data being in one place. Larry, have you encountered these concerns, and do you have any concerns of your own about what this could lead to?
Well, certainly, customer data, patient data is, the highest priority for, all of us that are in, the delivery system. And I do believe that, we're creating an intersection. I think the administrator said it very well, that, being able to, I'll use, the confluence of medical and pharmacy data certainly can, provide a more holistic view of the patient, provide interventions earlier, and the opportunity to provide better outcomes and lower cost. I think one of the opportunities that we do have is, the opportunity to look at, I'll say de-identified data by patient populations. And, if we took a group of patients with diabetes and, followed, their treatment, if you will, to understand, where do they fall off from the compliance of their regimen of care, if you will, and to be able to identify the commonalities across, populations, and then the opportunity to build, products or services that, that would close those gaps. I do think that there's an opportunity there to, get a significant way forward, without, being in a position where we must look at, individual personalized patient data. Certainly, being able to, personalize it takes it to another level. And I do think that, we'll get to the point where, it will be important for, the patients to, better understand how, their data is utilized, and, and for them to be, in control, as the administrator talked about, in terms of, perhaps opting into, those more personalized programs, so that they have a complete understanding of, how their data is being used and how it, can help them from a clinical perspective and an engagement perspective.
There's a data piece here too, which shows the power of data without compromising privacy. So Larry and I spent 2 days a couple of years ago on the opioid crisis, trying to figure out what are the tools that we can use as a society to stem at least some of that. And what we discovered, and it's of course all quite obvious at this point, is we have a philosophy about treating pain and an independence of doctors that basically we want to protect. and allow doctors to prescribe what they think is appropriate for pain. But you've also got a state system, a pharmacy system, which often does not have big data tools to look at what's happening. So if I've become addicted to opioids, I can't get it from whoever I was getting it from before. I'm going to go someplace else and I'm going to get a prescription, maybe a pill mill, maybe someplace else. But when you start to say, okay, now let's work together, let's figure out from an insurance perspective, not by name, but by system, how many different places you've gone for opioids, so that the docs can see that this is not what it appears to be, and you can start to prescribe differently than you would have prescribed before. You will end up, again, never disclosing somebody's information in a public way, never compromising it that way, but arming the doctors to have so much more information to figure out what's really going on in their office, which they couldn't figure out before.
Let's talk about telehealth for a minute, which I mentioned at the beginning of our discussion. I was actually just looking at a study last week, and I forget where it was, but talking about how some of the underserved populations that could most benefit from telehealth, who are perhaps a geographical distance away from providers, actually aren't using telehealth to the extent that they could. What are the challenges there and also the promises? And I'll let any of you take that.
I'll start from our end. I think that telehealth is very exciting in terms of what the potential is to how it can be used. It's not just being able to talk to the provider, but really staying in touch with the provider, basically monitoring the patient, being able to look at some of their data. Some of the challenges, though, I think, on innovation and having the adoption of telehealth, actually, I sort of feel like part of it has been the government and the way the Medicare program has been structured. Essentially, we haven't been able to pay for telehealth within the Medicare program. It's very clear that it was only able to be reimbursed in rural communities. So you can see why providers don't necessarily want to invest in that if they're not going to be reimbursed for it. So one of the things that we've done very recently is to change that and to allow use of more remote communication technology in the Medicare program. We also had the Bipartisan Budget Act that just passed as well, that's allowing more use of telehealth within the Medicare program and Medicare Advantage and in our fee-for-service system. So a lot of it, and I think this really goes to some of the issues with government-run healthcare and why, from my perspective, we're sort of very concerned about Medicare for All, is because you can kind of see when it's controlled by the government, any type of change that we want to make has to go through a long legislative process. And what's happened around remote communication technology and telehealth is a prime example. This has been going on in the market for many years, lots of promise, very important for Medicare beneficiaries who have difficulty, if they're elderly, have difficulty with transportation. And this could have been something that it could have been helping for many, many years, and it's just now becoming available. So now that we're starting to pay for it, I think you're going to see more widespread adoption of this. I think you're going to see providers using it more often. In some cases, we've seen when it's been available that consumers are still getting used to it. But I think with having more reimbursement, you're going to see wider adoption of this. And I think this has the potential to really help us on some of the access problems, and especially in rural areas. But also, we all live in the DC area. We know how difficult traffic can be. So that's not just a rural issue, it's also an urban issue.
Larry, do you see a role for telehealth in your corner of the healthcare space, and has it been underutilized?
No, I think the administrator described it very well. I think one of the challenges that we have broadly with technology is if you look at the rules or regulations that govern the practice, as new technology enters the space, how quickly do those rules and regs, get updated to create enablement? And I think, as the administrator pointed out, I think the use cases, are beginning to be well defined, whether it's increasing access to I had someone describe it as a primary care physician desert, that existed, or perhaps expanding the role of specialists where they're not readily available. I think people who have used, telehealth in that regard, give it extremely high marks for, its quality as well as its access. So I do think that, it can certainly You think about the role of the retail clinics. It can expand the scope of practice in those clinics and quite frankly, allow that nurse practitioner to practice more to what we would describe as the top of their license, by engaging a physician when and where appropriate.
We've touched a little bit on regulation, but I'd like to hear from all of you. First, what do you see as some of the most promising technologies that are being developed? And then is there a regulatory role here? And if there's too much regulation, can that impede some of the developments of these new apps, these new tools for people? I don't know who wants
Well, we see regulation. That's usually us putting out pages and pages of regulation every day. Yes, I think that regulation and some of the government rules have been a barrier to innovation. It works really well with sort of Me Too technology where it's something similar and we're already paying for it. And so if there's something new that's competing with it, it's very simple. They can say, all right, well, we're just going to pay that same amount. Where there's been difficulty is new technology that's coming out on the market and it doesn't fit in and we have to figure out a way of pricing for it and we don't have a reference for it. One of the things that we try to do is to work with the FDA so that as they're reviewing devices that we can try to do a parallel review so that when it's reviewed by the FDA and they say it's safe and it's effective and it can be used, that we immediately have a payment code right away so we can start paying for it and try to expedite that as possible. The other problem that we have, because a lot of our rules come from Congress and they're by statute, and so Congress tells us in the Medicare program what we can pay for. And if it's not something that's very clear, if it's not a device or it's not a supply, it becomes very confusing. And we've had difficulty, for example, on diabetic monitors, for example, have been difficult because if they use a particular app, it's like it doesn't fit into our nice, neat boxes. And I think, again, sort of the problems with government-run healthcare is that it relies on an act of Congress, whereas innovation and technology are moving. And if government isn't able to keep up with that, you're thwarting innovation, and people don't want to make those investments because it takes so long for those technologies to be paid for. The other thing I think we're thinking about is instead of innovators having to come to the government every time they come up with something new and prove it to us and us trying to figure out how to pay for it, if we can pay for healthcare in a different way, where we say to providers, here's your budget. People hear about this in terms of value-based healthcare and changing the incentives and saying, here's your budget. Then the provider can go out and figure out what's the most innovative device or tool to take care of the patient in the most cost-effective way. And then we don't have to have the government saying, yes, this device and this procedure, this is approved and this is how much we're paying for it. So if we really move the way we are paying for healthcare to more bundled payments, to more of a budget system, that I think will also help spur innovation.
Larry and Arnie, you both have the ear of a top healthcare official right now. What's your wish list for her? What would you like to see get done?
I didn't bring my pen and paper today, so keep the list short.
Well, I think what the administrator has talked about, I think, are real keys to unlocking value. The role of the EHRs and the linkage that can exist in terms of as technologies advance. How do you, the way I think about it is, how do you sync it up with clinical guidelines? It's clinical guidelines that, that really drive the bus around, treatment, payment, and ultimately outcomes. I think Paige, just picking up on that question, one of the things that we're exploring, it's probably a variation on this theme is, we're particularly intrigued in terms of what is the role of wearables as we go forward. And there's so many, chronic conditions that we're treating now that, are asymptomatic to some degree. And, can those wearables, help a consumer, because I'm using the terms consumer and patient interchangeably now, okay, that, be able to monitor their condition and, will a little bit of oversight, be an early flag to, it hasn't happened yet, but based on what I'm seeing, there is a chance of an unintended medical event coming. And our ability to, head that off can be, tremendously helpful. And that's something that, that we're beginning to do work to try to understand. If someone simply has, gee, I'm not feeling myself today. We've all had those days But all of a sudden, if we see that they've only taken 500 steps, and that may be asymptomatic to, a condition that they have, can we intercede, days before, if left unattended, 4 days from now, they're going to have a medical event that's going to require a visit to the ER, hospitalization. Those are things that we're trying to figure out what the linkage or the predictability of that is.
Arnie, I'll let you have the last word.
I mean, this is one advantage of employer-provided health care. So we are
You don't
less.
have to deal with the government.
Well, we have to deal with the government, of course, around healthcare policy, which is a perfectly appropriate place for the government to play. But I think we can experiment with our partners and say, you know what, let's use that smart device, help somebody monitor their diabetes or their MS, the two examples that are very real and we're in the market with right now. And as long as we think it's going to deliver better care, better health results at a cost-effective approach, we don't have to wait for the government to say it's okay to pay for that. We can find a way to get that done. And of course, that's one reason I think we ought to, as a society, continue to learn from all of these different healthcare systems. And we ought to be pretty cautious about saying we're going to do away with some of these healthcare systems in favor of single payer or something else. Because done right, we can learn a lot from all of the different tools that we've got out there.
And I will say, I'll give the administrator a lot of credit for, being open to what has proven to be effective, in the commercial sector, private sector, and, understanding that in terms of its application in government-sponsored care. So thank you for that openness.
Well, a big thanks to all of you for being here. This has been a great conversation.
Thank you.
Thank you.